Welcome back to Mostly True Psychiatry with Dr. Mellon. Today we're going to be talking about 5 drugs you're likely to try after your SSRIs and SNRIs. I just picked like 5 that are built over a long time frame, from new to old, different mechanisms of action, all that good stuff. I'm only going to spend a couple minutes on each drug. And again, dosing and stuff's not done in this video. That'll be in the next one. So Bupropion came out in 1985. So this is supposed to be the fantastic drug for reduced positive affect, meaning it's activating. So it should help you with low energy, poor self-confidence, loss of joy. That's basically based on the HAM-D research, a specific question number 13. It said general somatic symptoms. The symptoms are heaviness of limbs, back, head, backache, headache, muscle aches, loss of energy, none, some, lots. And they supposedly found a big difference. I don't know if it's true. Psychiatrists could be good at selling a placebo effect in a story. I have no idea. So research involving this drug. So one thing that's really cool about being an old drug is it's been researched a lot. So short normal studies, 6 to 13 weeks, up to 52. It's been directly head-to-head tested against other SSRIs like paroxetine, sertraline, fluoxetine, the SNRIs, venlafaxine. It's been tried in old people. It's been tried in young people. It was part of the STAR-D, and it's been tried against the TCA. So, I mean, way better research than most of the drugs. On their big meta-analysis, it makes the top 4 is a good antidepressant medication. So this particular drug should probably be a first line, even though it's not. So the mechanism of action, I thought it was supposed to be an SSRI. We needed SSRI to make them work. This is an NDRI, norepinephrine, dopamine reuptake inhibitor, just as good as a TCA or citalopram or whatever. And it's a weak dopamine and norepinephrine transport inhibitor, so more dopamine than norepinephrine. Dopamine is supposed to be the feel-good drug, and that's the argument statement there. It's pharmacokinetics. It's super important. I'm just going to point out is it is heavily metabolized as active metabolites, and your liver must function well to use this drug. If your liver functions well, it's fine. If it's not, the 2D6 system's really going to mess this up. It basically, if you take a strong 2D6 inhibitor or you don't have a good liver, it will increase the area under the curve of this drug, the total serum level, by 3x, pretty easy. And the side effect of fear for this drug is seizures. So let's get over there. There we go. So they found out when they were doing the IR, which I'm sure it wasn't called originally, when they gave 350 to 450 milligrams, 0.4% seizures. Not too great. That's close to kind of where the bad drugs are that are still allowed. And that was like 13 out of 3,000. Then when you increase up to 16%, it jumped to 2% already. So it took off the market. It was taken off the market for like 3 years. They did a sustained release, and that reduced it. And then they did an extended release, and it reduced it even more. Realistically, we still say this is a seizure risk. It's 0.1%. It's like 0.05% for the SSRIs and SNRIs. And it's kind of on par, really, with the antipsychotics. And we don't get all caught up and confused and scared about seizures for that. Other than that, the side effect profile is usually not too bad. People can think it's a little activating, that kind of thing is the argument. Make you have a little more energy and stuff, even though it's just as good for anxiety as kind of the meta-analysis now. So take it for what it's worth, right? Lamotrigine, Lamictal. So this is an interesting one that some folks really like these days. So it came out in 1995. It's an AED, so it's an anti-epilepsy drug, which basically, for us, it's considered useful for bipolar II disorder. I think that's the reason bipolar II disorder. These drugs are the only reason that diagnosis really is given a lot of attention in psychiatry, and is because drug companies found a way to latch on their meds. But, you can give it for depression. It takes 2 months to titrate, maybe 3 months to work. If you want to wait 5 months to help somebody with depression, then yeah, cool, go for it. Mechanism of action is, I'm going to just say magic unicorn. It's a voltage-sensitive sodium channel and calcium channel blocker, just like the other versions, like the other AEDs. So like Keppra and stuff, They've tried to come up with a lot of, cool story bro setups to try to prove that it might have a link to actually helping anxiety and depression. I don't know if there's any logic to it really, other than they can prove that you can put a loose chain of events together. It's pretty clean drug, not a lot of side effects really. That's good, other than the one big one we'll talk about in a second. It basically gets gluconated, and then it stays the original molecule, and you pee it out. Doesn't get affected by the liver and the kidneys a lot, so it's a real easy drug as far as side effect or the way the drug works and drug-drug interactions, which is cool. It is a seizure medication. They all carry big risks of malformation for little babies, so. Bipolar 2, commonly given for people who probably have PTSD. They get a diagnosis of this setup, and you giving every 20th kid, if you wanted to make a conservative kind of mean angle to it, to have major malformation risk, maybe lower their IQ, do something great like that. The black box warning is really the story you care about. So SJS, it's toxic epidermal necrolysis, or otherwise known as Stevens-Johnson syndrome, and I'm just going to point at this one piece. So originally, Lamotrigine was a seizure medication. They went 100 milligrams, and they went to 400 by the fourth day. They increased 100 milligrams each day, and they had Stevens-Johnson syndrome 10% of the time. So they went, no, we have other drugs that work just fine for seizure. They walked away. And then Psychiatry is like, looking around, trying to figure out more medications, and the drug company's like, hey, look what I got. I bet this works for bipolar too. And we all jumped on board. And so this drug is still regularly prescribed for that. The next one we're going to do is going to be Mirtazapine. I'll put in the trade name Rimron because it'll be faster to find in the brain. Okay. So this one came out a little bit later, 1996. The big thing with this, it's its own special little category. It's a proven alpha-2 antagonist antidepressant. It's still old enough that it's been tested a lot. It's been done head-to-head trials. I mean, it's against the TCAs. It's done against the SNRIs, the SSRIs. So it's awesome research compared to lots. That's one good thing about older drugs. So it should be just as good as the other drugs. The side effect profile basically be the thing that helps dictate how you prescribe it. Then there's the cool story, bro, that you can Mirtazapine plus SSRI equals California rocket fuel. This is a great combination. It's bogus. They tried it for up to a year almost in England as a RCT for placebo-controlled with like 500 people. They couldn't tell the difference between adding it or not in a placebo. So more stories in psychiatry that aren't holding up. It's a weird drug. It used to be called a tetracyclic. Like you have a tricyclic antidepressant, so it's a tetracyclic antidepressant, and then they tried to call it a NASSA, which is the most garbage thing I've ever heard. So that's what they try to promote it as now, is saying it's a noradrenergic and specific serotonergic antidepressant. Which serotonergics? There's a bunch of them, right? Like that doesn't mean anything. Otherwise, 5-HT1 is the same as 5-HT2, and D1 is the same as D2 and D3. It doesn't make any sense. So it's mostly 5-HT1 and norepinephrine agonism are the big selling points for it. So you get a little bit of the SNRI kind of concept, and you get the a thing that's kind of promoted nowadays is supposed to be helping with depression, with 5-HT1 and the prefrontal cortex and all this stuff. The theories are pretty soft. The metabolism stuff to know is it has active metabolites. It's a racemic mixture. It takes several days for them all to kind of build up, like 7 days or so before you get to steady state. It gets gluconated and ends up in the basically all peed out, really, or a lot more than most drugs would do. The metabolites don't really make up a lot of the actual milieu. So for the side effects or things to think about with mirtazapine is so you give mirtazapine to help a person sleep, right? It's 15, 30, 45 milligrams. The first 15 milligrams are complete sedation, so the side effect's sedation, and that's an awesome effect whenever you're trying to help somebody with sleep problems. So that's the best patient, right? It's like they have sleep problems. It's pretty safe. You have to eat a lot of it, like a bottle, and it's not that much worse than like SSRIs. It's a little bit more dangerous as far as fatality rate, but not by much. Doesn't interact with a lot of other things. It has this risk. I still don't ever see people pay attention to it really, but so it has an A and C reduction, and then so that'd be like an A granulocytosis risk. That's like a clozapine kind of risk profile. So you're looking, so probably don't add it with clozapine. Aripiprazole, Abilify. So, sorry, I'm typing in the trade names because it's easier to search for me right now. Came out in 99, a couple years later. This is a third generation antipsychotic. And it got shoehorned in as being basically also good for bipolar 2. I think this is going to be a trend for a while because it seems to give them a soft in to be able to get these drugs passed. It was a #1 selling drug in 2013 and 14 with over $7 billion of profit made. And so like good psychiatrists were holding water for him and running behind him and going, this is great. It doesn't cause weight gain. It doesn't do this and that, just like they said. So the mechanism of action, it's a third generation antipsychotic. So it's a partial agonist for D2, 5-HT1A. And that's really kind of all you need to know. It's magic a little bit on depression. I don't get it, but that's okay. The side effects, you're just anything you're thinking of for a basic antipsychotic, just think of this drug. So weight gain, diabetes, etc. They say it's weight neutral or very little. I don't believe that personally. I've seen a patient on 15 milligrams in the span of 2 months gain like 25 pounds. So I don't know. I mean, they could have just been eating a lot, and I fixed all their depression symptoms, and they went from starving to eating. But they were normal BMI when it all kicked off. And then we go to one of the two new drugs. We'll pick Velazodone. So, oops, missed it. We'll jump through 2 more boxes. We'll get there. So Vibrid, one of the new fancy drugs. This one came out in 2011. So it's called Vilazodone. It's structurally similar to nefazodone and trazodone. It's been described as taking buspirone plus citalopram, because citalopram is a very clean drug, so that's one we want to compare it to as an SSRI, and then 5-HT1A. But Velazodone is 60 times more selective than buspirone for 5-HT1A, so I'm not sure. And I'll jump to the chase. There's no real research on these drugs still. They're not done head-to-head trials and all that stuff that are worth a damn. The mechanisms of action, so they're SPARIs, so they're a serotonin partial agonist reuptake inhibitor. It's actually kind of interesting. So it's an SSRI and 5-HT1A. It's a 50-50 split on how it binds. It's hard to know what any of this stuff means in the long run. That's why we need these drugs to be 30 years old and tried against other stuff. So it's, like we said, it's 60 times more potent than buspirone, and then it's 30 times more potent than fluoxetine. So the dose and everything matters a lot. Any cool pharmacokinetics to share at the end? So it's highly metabolized. They investigated it up to 80 milligrams, which is double how we prescribe it now. It really goes through the CYP3A4 system. So if you're on a strong inhibitor for 3A4, like erythromycin or ketoconazole, it's going to spike this drug up. And here's the cool thing to know about this drug that they don't like to promote, but it deserves a lot of attention, is its side effect. So withdrawal is the same as an SSRI. It's going to cause all the same problems. It's going to have the same side effect problems as SSRIs. They're going to say no sexual side effects. Maybe it's true, maybe it's not. I don't know. It could be another cool story, bro. So here's the common side effect that really needs to be paid attention to. We say diarrhea, headache, nausea, and you're like, that doesn't sound bad. 1 in 5 people dropped out of the studies because it was so bad. And if they had any kind of CYP3A4 problems or the dose went up too quickly, massively dropped out and had problems with like nausea and vomiting. They even like saying, oh, do we need to give the drug again if they threw up in the first 7 hours as part of the studies. So yeah, that's not trivial. All right, there's your quick blast through. Next video on Mostly True Psychiatry, we're going to be talking about basically the actual prescribing for all these drugs, on how much you give and how to prescribe it. It's basically you just need a 1-page table and you'll know what to do. All right, take care, everybody.